All right, well, let's go ahead and get started. Welcome, everybody. This is Dave Haas hosting our monthly installment of the Tennessee CFAR seminar series. To remind folks, these are installments we do each month, this day and week of the month at this time. Sometimes with local investigators at our Tennessee CFAR, which is a four-way partnership between Vanderbilt, Meharry Medical College, Tennessee Department of Health, and Nashville Cares. And other times we are very blessed and fortunate to have guests join us for our this seminar. And today we are in the latter blessed category to have three investigators joining us from the University of California, San Francisco program. We have Beth Bourdeau, Parya Saberi, and Greg Rebchook joining us to talk about some exciting work that they will dive into related to treatment enhancement at home with long-acting injectables. So before we jump in, to remind people of a couple things. One is please mute yourselves when you're not speaking. The second thing is if you have comments or questions as we go along, please put them in the chat or in the QA function in the Teams meeting. We are recording this session as we do all of our seminar series, so be aware of that. So now I would like to turn things over to Parya Saberi, who has graciously volunteered to do the introductions of our speakers today and take it from there.
Great. Well, thank you so much, Dr. Haas, and thank you so much to the Tennessee CFAR for inviting us. I'm Parya Saberi. I'm a professor in the Division of Prevention Science at UCSF, and I'm going to be presenting this about the study of the interim findings of our Invite Home study with my colleagues and co-investigators, Drs. Beth Bourdeau and Greg Rebchook, who are also faculty at UCSF. So Invite Home stands for the Innovative Administration of Long-Acting Injectables for HIV Treatment Enhancement at Home. And it was funded by the CDC. Many thanks to the CDC for taking a chance on us. And it was in response to an RFA on long-acting injectables for the treatment of HIV in non-clinic community-based settings. Next slide, please, Beth. And so we have three sections that we're going to focus on. The background is Beth will cover, which is really talking about the promise of long-acting injectables, our study design framework, and our wonderful team. Greg will cover our AIM-1, mainly focusing on the formative work that we've been doing and have already completed. And I will come back to talk about our AIM-2, specifically on our pilot study and the main trial that we just launched. So with that, I will turn it over to Beth.
Great, thank you, Parya, and thanks to CFAR for hosting us. It's lovely to be here. So I'm going to talk about what brought us to the point of our project that we'll be sharing with you today. So I'm pretty sure folks know a little bit, at least, about injectable ART. There are a number of things that we think really make this innovative and an exciting new field in terms of being able to treat more people. First of all, there is a lot of interest. There are a number of surveys that have been published on ways that people with HIV would prefer to receive their treatment. Injectables has been ranked really highly consistently over the last few years. It does give people the freedom from daily pills, and then also the reminder every day that folks are living with HIV that having to take daily pills, in addition to sometimes having to take kind of a high number of pills. And this is a way to relieve pill burden. It's also a great way to address increased adherence with fewer administrations, and there are fewer opportunities for folks to miss a dose. That said, there are a lot of complications that come along with providing injectables. One is that folks will need to go back to the clinic more often than they would if they were on oral medications. That also folks can experience stigma with those increased clinic visits. And so they may not have the reminder every day, but they do have the reminder when they have to go back to the clinic fairly frequently. For clinics, there are a lot of more kind of structural issues that prevent some barriers to putting together an injectable program. Those involve needing to have trained staff to do the intramuscular injection personnel, to have those folks trained, and then also to have a private space to have those done. If folks are not aware, you do need to partially disrobe in order to receive those injections, and so there needs to be a private space for that to happen. There are also some storage requirements. Rilpivirine is required to be refrigerated, and so there needs to be set aside space to keep the meds ready to go. There's also the additional, just the workload of having patients come in more frequently. Scheduling within the 7-day window before and after the regular administration, and then also rescheduling when that needs to happen, and then just having more folks come in more frequently can increase the workload for clinic staff. So that brings us to why then think about home-based as an alternative to clinic-based administration. First of all, it's been home-based delivery with a treatment buddy has been used with success with other conditions, fertility treatments, asthma, diabetes, some treatments for multiple sclerosis. So we thought this might be a good approach to opening up some of those barriers. It will reduce travel and time burden for folks as they're not having to go to the clinic, especially if they can have their meds delivered to their home. It gives them some more autonomy and flexibility, takes a lot of that kind of administrative and workflow burden out of the clinics. And ultimately, our goal is that it would expand equitable access, that might be a method for increasing scale up of long-acting injectables. As noted, there is a strong patient interest. So there are a number of surveys, including one of ours, looking at how would you like to receive injectable ART if you wanted to go onto injectables over oral pills, and being able to do it at home is often ranked pretty highly among people with HIV. So to date, there's no study of implementation to evaluate how to implement and support this model into real-world settings. So that's what we are here to do. So Invite Home was devised as a response, as Parya had mentioned at the very beginning, to an opportunity being offered by the CDC. This is our research team that we pulled together. The three of us, Starley Shade is our lead quantitative evaluator, Mallory Johnson is a social psychologist, and Orlando Harris, an HIV nursing professor. Our study clinician, our fabulous study clinician, Jonathan Van Nuys, is a nurse practitioner and has worked in HIV for a very long time. We have our qualitative and quantitative analysts, Alicia Bolton and Michelle Palomares, our project director, Erin Moore, and then also we'll mention later on our community advisory panel. Right now, we are working with 4 clinical partners in the Bay Area. So one of those is Ward 86, a Ryan White Safety Net Clinic, a women's HIV program, which is a clinic located within UCSF, as is 360 Wellness Center. Those focus primarily on different genders or categories. And then we also have partnered with Highland Hospital, which is a clinic that provides HIV prevention and treatment in the East Bay. So the overall study design that we'll describe in more detail today, aim 1 was really just to do the formative research, talking with clinicians, people with HIV, about what their needs would be to design a model of home-based administration, and then to go through and develop the intervention. Aim 2, we'll talk about, was first a pilot study, and then our larger hybrid type 2 implementation effectiveness. And I am not going to go into the detail on this, except to say that we use the implementation of research logic model to start to conceptualize all of the factors that would go into what we should look at for assessing at-home implementation. So those are guiding our data collection decisions and also the kinds of things that we attend to as we're implementing the program. And at this point, I'm going to turn it over to Greg Rebchook.
Thank you so much, Beth. I'm happy to tell you more about our AIM 1. Oh, can you go to the next slide, please? So again, our goal for AIM 1 was more formative in nature, and AIM 1 really assessed the feasibility and acceptability of an innovative, theory-informed treatment buddy training for the administration of LAI-ART in home-based settings. We used both qualitative and quantitative methods to conduct the formative work necessary to develop the training. The quantitative methods determined interest in receiving LAI-ART at home from a treatment buddy and willingness to participate in the study once recruitment began. And our qualitative methods identified training barriers and facilitators, as well as training needs and preferences. Next slide, please. So our participants were really in 3 groups: clinicians who were providers delivering LAI-ART at partner clinics, and those included physicians, pharmacists, registered nurses, nurse practitioners, and social workers. And they were referred to our study team by the clinic leadership to participate in interviews that we did with them. We also had people living with HIV who were receiving LAI-ART at partner clinics, and they were recruited into the study via flyers that we posted in the clinics where they could contact us directly, or their clinicians could refer them to the study. And then we had candidate treatment buddies who were identified by the participating people with HIV, and those generally included trusted partners, close friends, or family members of the person living with HIV. Next slide, please. So our eligibility criteria included, were a little bit different for each of the groups, but for our I can see the quantitative brief interest survey, everybody in the study had to be 18 or over. The brief interest surveys were for people living with HIV who are receiving LAI-ART at participating clinics. They had to speak English and were able to complete an online survey. The qualitative interviews included people with HIV who, again, had to be over 18, were receiving care at a clinic, and were also already on an injectable, and they needed to be able to identify a treatment buddy to whom they had already disclosed their HIV status. The candidate treatment buddies also had to be willing to consider providing injections to their person with HIV, and the clinicians needed to both work at a partnering clinic and would consider referring patients to the treatment buddy program. Next slide, please. So our formative data sources really came from the 93 brief quantitative surveys that we did to ascertain interest in participating in the study. And we also used those surveys to help identify people who are willing to participate in the formative interviews. We did 19 interviews, and when I say we, I really mean Jonathan and Alicia, who are both here on this call. So we really appreciate all of their work doing these interviews, and I'm really privileged to be able to describe the findings of them. So we did 19 interviews with clinicians and 31 interviews with PWHs or potential treatment buddies. And those interviews were really to inform our workflow, the design of the intervention, the design of the training, and the tool development and refinement. So next slide, please. And so I'll talk a little bit more about the findings. So Michelle, if I get anything wrong, feel free to jump in or correct me afterwards. But we did a survey with 93 people with HIV, and we classified them as either enthusiastic about the study, if they were both interested in home-based LAI-ART and were willing to be contacted for recruitment. And then the people who didn't have those characteristics were classified as not enthusiastic about the study. About 2/3 of the study participants were classified as enthusiastic, and 85% of those said that they could identify a potential treatment buddy. We also collected data on age, gender, race, ethnicity, and how long they had been on ART. Oh, I can see that this table didn't quite make it onto the Zoom quite right, but I will tell you that there were very few differences between those who were enthusiastic about it and those who were not. The only significant difference were those who identified as Asian, Native American, Native Hawaiian, or other were less enthusiastic than those who identified as white, though we still don't really have a great explanation for why that is. Next slide, please. So then from our interviews, and I should say that all the interviews in the study were conducted via HIPAA compliant Zoom, and all the participants received a $40 gift card. And our qualitative analyst used field notes and transcripts to conduct thematic coding. And so these are the anticipated barriers or anticipated benefits that our clinicians mentioned during their interviews. Those included reduced transportation and scheduling barriers, more convenience and flexibility for patients, increased privacy and receiving care in a familiar environment, which was perceived as an advantage, and the idea that home-based LAI-ART would really support patient-centered care and autonomy, and had the potential to expand clinic capacity because more people could be receiving injections outside of the clinic. And you can see that one physician said, the more patient-centered we can be, the more in line it is with people's lives, the more likely people are to succeed. Next slide. But the clinicians also had some anticipated barriers that they mentioned, and those primarily focused around injection accuracy and safety concerns, how to store and manage the logistics of getting the medication and administering that effectively, treatment buddy availability and reliability, potential communication gaps between teams and patients, and insurance billing complexity. As you could click one more time, we'll see a quote from a registered nurse who said, the injection itself isn't the hardest part. It's everything that goes into getting the medication, storing it, tracking it, and making sure it happens on time. Next slide. And you can see that what we tried to do is to map the barriers to facilitators along various CFAR domains, including intervention characteristics, inner setting, outer setting characteristics of the intervention of the individuals and the process. So for example, if you look at the inner setting determinant, you can see that one facilitator that emerged was the orientation to shared decision-making, and that several barriers emerged around capacity for monitoring remotely, providing necessary supplies, and ensuring timely injection administration. And some determinants could also be considered both facilitators and barriers. For example, communication and documentation capacity could be a facilitator if the communication is going well. It could also be a barrier if there's a communication problem. We also did this with I'll just say it. If you want more information about that, I highly recommend looking up Dr. Bolton's paper. It's really well written and is a nice example of how to map facilitators and barriers onto the IRLM determinants, or IRLM, sorry, along the CFAR domains. I'm confusing myself. Next slide. So then from the 31 interviews that were done with the people with HIV and their treatment buddies, or potential treatment buddies, they had a variety of advantages that they saw to home-based injections. Those included transportation. Some of the participants were as far as 2 hours away from their clinic, so receiving the injections at home would be a great advantage for them. Privacy and stigma, because they see an HIV clinical space is a big plus for multiple respondents. Comfort, that people felt that the care would be much more personalized being at home, and felt that home was much more quiet, calm, and simple than the busy clinical settings that they were getting care in. And that it would be very empowering because it would give them control over their care, and both them and their treatment buddies could learn new skills and increase their knowledge. And of course, it generally improved convenience and access to care. So one person with HIV said it would just make life easier, not having to go back and forth to the clinic all the time. Next slide, please. Some of the anticipated barriers that they talked about really emphasized the importance of a comprehensive training and clear procedures. They definitely wanted step-by-step instructions for injection processes and emergency procedures in the event of something like a needle stick. They really asked for ongoing check-ins and scheduling reminders, and that it was important to note that it wasn't just about the logistics. It was also one of the barriers was really on the more emotional level, because emotions really mattered. The people with HIV might feel vulnerable by handing over their treatment and the injections to a treatment buddy, and the treatment buddies would have the emotional weight of the responsibility. So that the treatment buddies and the people with HIV really had to be emotionally ready to participate in an intervention like this. And of course, there were other, more, I don't want to say mundane, but logistical issues around insurance coverage and cost uncertainty, as well as safe disposal and supply access. Next slide. Oh, sorry. And then one of the treatment buddies says, "What do I do? What if I do it wrong?" Sort of illustrating the concerns around the emotional piece of, not wanting to do anything that would harm someone that they care about. Next slide. And so again, I think the importance of selecting the right person to be the treatment buddy was really important because of the relational nature between the treatment buddy and the person with HIV. And we'll get more into some of these in the next couple of slides. Next, and then you can see here that the person with HIV said you really have to trust the person who's going to be their treatment buddy. Next slide. So the central role of the treatment buddy is clear. The relationship has to demonstrate consistency, commitment, and emotional readiness. And issues like unresolved conflict or unpredictability really risked undermining the relationship. Another thing that came up on a more logistical level was just the availability and proximity of the treatment buddy, that it wouldn't necessarily be helpful if the treatment buddy lived 2 hours away and had to drive through rush hour, because then it would just move the transportation concern from the person with HIV to the treatment buddy. So that you had to really be careful in selecting somebody that you both had a good relationship with and who had the logistical wherewithal to be a good treatment buddy. And in the next slide, you can see some of the home-based considerations that emerged in the interviews, really saying that the environment needed to be clean, distraction-free. There had to be the furniture had to be at the right height for safe positioning, and there had to be enough room in the person's living situation to administer the gluteal injections. We needed reliable refrigeration for medication storage. And the process for secure medication delivery and handling. Sometimes people were already getting certain medications delivered at home, and that made them more likely to feel like this would work. And we needed processes to get their injection supplies and the sharps disposal. And of course, people mentioned things like making sure that they don't have a dog that's going to jump on you during the injection. So the next slide summarizes our key takeaways, that there really was strong interest and enthusiasm for home-based LAI-ART. The treatment buddy relationship dynamics are central. The training really has to address both the tactical skills and the emotional readiness, and that it can't just be a one-time thing. It has to really be an ongoing system of clinical support that would be important for implementation, so that they wanted it to not just be once, but wanted to really have an ongoing relationship. So I think with that, I will turn it back to Beth, who's going to talk about product development.
Thanks, Greg. So then our next task was to put all of this together and come up with the actual intervention manual. So to come up with all of the materials that we needed to provide this as an intervention before we could get started, there were a few things that we brought together. So one was that the work that we did was guided by adult learning principles. We consulted with some curriculum developers that are available to us through the Alliance Health Project, which is a center at UCSF that does a lot of training development. We also consulted our 10-member community advisory panel, and those were made up of our interview participants who said that they would come back and provide feedback. A lot of them were really interested in seeing what we came up with after talking with them in their interviews. We also have a number of folks on our team who have designed implementation toolkits and have expertise in implementation science, developing and providing programs. So we brought that to the process as well. And then I want to give a shout out to the LAI-ART team at Columbia. LAI-ART, if you're not familiar with them, is a demonstration project funded by HRSA Ryan White that looked at providing a toolkit for setting up an injectable program within a clinic. So the implementation products that we came up with for getting started, first of all, of course, is the training curriculum and other supportive materials. Those include training videos, slide decks, and training supply kits. We also developed a TBY, our treatment buddy selection tool, and we have a clinic coordination protocol, which is made up of a discussion guide and a protocol template. So I'll give a little bit more detail on those. The training development process, we started with reviewing the existing training materials. So there were materials and little cheat sheets and guides that were available through the drug manufacturer. We started out with Cabenuva. So we looked at those materials that they would provide to the clinic. We also requested a live demonstration training from a drug rep. And so we were able to all meet in person and go through and test out what exactly it would be like to provide the injection. One of the things that we looked at when we saw those materials was, of course, they're designed for clinical audiences. So they were instructive in terms of step-by-step instructions, but were also at a very clinical in their language. And so it needed to be adapted in order for us to use them in this setting. We integrated then, of course, the findings from the formative work that Greg just described. We went through and worked with the, as I mentioned, the curriculum designers at AHP, and took it back to our community advisory panel, gave them a demonstration of the entire training, and gave them time to respond both to surveys in terms of engagement and effectiveness, but then also had a lot of time for open discussion. That led to our final refinement and then preparing to implement. The things that we kind of took away from all of this, there needed to be structured hands-on learning. Of course, this is a physical activity that requires a high degree of accuracy. So it needed to have time for actual physical practice. We wanted to provide multimodal training materials. So we wanted to have things that were both didactic and interactive. We wanted to have things that were more geared for visual learners and more for auditory learners. As I mentioned, the materials that we started with had a lot of medical terminology in them. So we wanted to make sure that they were described in plain language and in ways that were easily understood by lay people. We also put into place protocols for injection safety and adverse events. So making sure that in case someone had a reaction, that particular injection, or making sure that we had a protocol to follow in case of a needle stick. And of course, ongoing clinic support. That was both in terms of our clinical team. As I mentioned, well, Dr. Saberi is an HIV pharmacist. We have a nurse practitioner. We also have our Orlando Harris is a professor of nursing and works in HIV. So we had clinical staff at the ready. As one of our interviewees noted, it's feasible, it's doable, it's a skill that's teachable. And I want to shout out here, this is Jonathan and Kate Buches, who is one of our CDC colleagues. This is our mannequin that we've named Cheeks. This is a human looking butt cheek mannequin that allows folks to actually perceive the bone landmarks and locate the precise location of the injection. We also give folks, this can be practiced on, so folks can use needles and saline and practice giving the injection on this mannequin as many times as they want. So in terms of the actual program or intervention, we put together materials that we ask folks to take a look at before their very first training session. Those involve videos and handouts. We also then use that same training that is presented in person in that first visit with both the person with HIV and the treatment buddy there going through the training. The first injection is done during that first training visit. The treatment buddy is able to practice as many times until they feel comfortable and our nurse practitioner agrees that they are using the correct process and technique. And then from then on, we offer ongoing clinical monitoring via Zoom. And this is Michelle and Jonathan putting together our goodie bags. So we do have these great little canvas totes with our logo on them. We take folks chucks, wipes, Band-Aids, stress balls, little hot cold packs, and gloves, and have everything ready for them to go. So as Greg noted, one of the biggest things that came out of this is really about the decision to select a treatment buddy. And one of the things that we're interested in is who makes a good treatment buddy? What are the characteristics that we really need to be attentive to? So we created a tool for that purpose using the interviews. We went through a process of domain mapping and tool drafting, pilot tested that on the pilot that Parya will talk about in just a moment, brought the tool back to the community advisory panel in a separate meeting from the training review, and then went through to finalize that. So the primary domains in terms of what we ask the person with HIV to consider as they're choosing someone to be their treatment buddy is around trust and confidentiality, reliability and availability, that person's perceived comfort with injections, whether they've done this before. We do have some healthcare providers who've worked with us on this as treatment buddies. Proximity and reachability. So as Greg mentioned, are they someone that could get there quickly? And then physical and emotional readiness. And finally, the last piece that we came up with, and again, the shout out to the folks that developed LAI-ART. It takes a lot of trust and coordination between us as a study team and our partner clinics, and we so appreciate them being willing to trust us with the care of their patients. So we do have a discussion guide. It's available on our website. We use the decision-making tool that LAI-ART developed to develop our own discussion guide of all of the things that we need to know about their process, all of the things that they need to know about our process to make sure that there's no gap, there's the same high-level quality HIV care for their patients. And then that discussion guide actually filters into a formal protocol, which is the agreement between us and our clinics. And I'm going to turn it over to Parya to talk about AIM-2.
Okay, thanks so much, Beth and Greg. So maybe if you can go to the next slide, please. So our AIM-2, it was, as Beth mentioned, was to enhance the understanding of the home-based LAI-ART intervention using all the training and everything that we developed in AIM-1. And we did this through an implementation effectiveness trial, so really moving from that formative phase into a real-world setting. Next slide, please. Unfortunately, we had a little bit of a hiccup last year due to some of the funding cuts. We were worried that there may be funding cut with our project. So we made a quick pivot to do a pilot instead of the larger trial, and really just to maintain the momentum of the study, given that there was this uncertainty with funding. And we thought this would be a great opportunity to test the feasibility of our workflow, really evaluate the training that we've developed in this, real world setting and get feedback from real participants and identify any operational needs so that when we do end up scaling up the trial, which we just started, we would be able to resolve a lot of the issues ahead of time. Unfortunately, as you may have heard, that the funding cuts, again, are at our doors. And there's 4 states that have had some potential for funding cuts. Fortunately, we're still alive and kicking right now. So yes, please call your representatives to make sure these cuts don't occur, because we really want to do the study, and we're really excited to see how the results are and how we can implement this in actual clinical care. So next slide, please. So for our pilot study, we looked at 7 dyads, and we only did this for 2 months, so really offering the first training with the first injection at baseline. So the treatment buddy received the training from Jonathan, our study clinician, did a bunch of practice runs and actually provided the injections. And then at 2 months, for most of the participants, we were able to observe them doing it via Zoom. And we really wanted to focus on the feasibility and acceptability. The results of this study are under CDC clearance right now and also have been submitted for IAS. So we're not going to be presenting the actual results, and hopefully we'll get invited back to present those along with other results of our study. For now, if you can go to the next slide, please, Beth, for the lessons learned was that overall, very high feasibility and acceptability, and we were able to refine our training and supervision workflows and identify some of the contingency planning. So, for example, what would happen if one day the treatment buddy, for whatever reason, wasn't able to provide the injections? How would we ensure that the person with HIV continues to receive their medications without missing a dose? We highlighted some structural barriers, and as you probably guessed, insurance constraints were number one, particularly among folks who did not have pharmacy coverage for their medications, for their long-acting injectables. There was some structural barriers, and we weren't able to enroll those folks. And then finally, we were able to inform our AIM-2 implementation effectiveness trial, which we just launched a few weeks ago. So next slide, please. So other new things that we decided to incorporate into this new phase is that we expanded our clinic outreach. So before we were working with 4 main clinics, and now we are able to expand the geographic outreach. We added lenacapavir injections for treatment. So for folks who are receiving cabotegravir plus lenacapavir or cabotegravir rilpivirine plus lenacapavir, we're able to offer training for both the treatment buddy injection or the self-injection of the person with HIV, because it's a subcutaneous injection. So it's actually, it might be somewhat easier for the person to self-inject into a fat tissue in the stomach. We also added 2 biomarker sub-studies. So one on the top image is a HemaSpot for looking at home-based viral load testing. Home-based viral load testing is still a little early on in its presentation to the world, but it's still something that we'd like to test out to see if that could be a possibility. So, to get in front of any additional barriers where participants would need to go to clinics to do viral loads repeatedly, they could do some of the viral load monitorings from their home. And the second testing that we added for biomarkers is a TASO, which is the photo on the bottom. And that is to look at drug levels so we can, just ensure that the drug levels that the individual with HIV has is similar to the ones that they were receiving at home. Next slide, please. So for our AIM-2 study design, we have this hybrid implementation effectiveness trial, and we use qualitative, quantitative costing and biomarker methodology for our study. So in the next slide, you can see that we have, for implementation study, we have our 40 clinicians that are going to help us with the implementation component, and 30 dyads of people with HIV and their treatment buddies. For the effectiveness trial, we have 250 dyads, and we have a non-randomized comparator arm, which are people with HIV who are continuing to receive long-acting antiretrovirals in their clinic. And then the biomarker substudy is among 25 individuals for folks who are just receiving CAB and rilpivirine. And the TASO, which is for drug levels, is going to be done at baseline, which is going to show us the clinic trough levels. So basically, we're doing the drug levels right before they receive the home-based injection. So that's the clinic trough. And then at 2 months, we're repeating that, or the participants actually doing it on their own. And that's basically going to be the trough level for the injection that they received at home from their treatment buddy. The HemoSpot is, as I said before, for viral load, and we're doing that at baseline and every 2 months. So next slide, please. So the implementation study is really looking at a lot of implementation outcomes such as feasibility, acceptability, fidelity, sustainability, reach, cost, facilitators and barriers for implementing this strategy at home. And we're looking at qualitative, quantitative, and costing data. So next slide, please. So for the qualitative data, we are looking at document reviews and then interviews with the clinicians, the people with HIV and their treatment buddies, and those are done at 3 time points. The quantitative methods are surveys with the clinicians, treatment buddies, and the people with HIV, again at 3 time points, along with reviewing electronic health record data, as well as costing. The costing piece is being led by our colleague and co-investigator, Dr. Sarli Shade, who is really developing a workflow for estimating the costing using the cost information for the personnel, their recurring supplies and services, the capital equipment, facility space, and it's a very a detailed review of costing so that when clinics go to implement it, they would have a better sense of how much it would be for them. So next slide, please. For the effectiveness study, as I said, we have this non-randomized trial looking at primarily at viral load as our primary outcome, comparing the home-based versus clinic-based LAI-ART. And we have a bunch of other outcomes such as side effects, appointment attendance, so looking at adherence and persistence on LAI-ART. Next slide, please. And then I already mentioned the biomarker sub-study, and this is really looking at satisfaction and just feasibility, acceptability with home-based biomarkers, and really more of a proof of concept of being able to show similar drug levels and ability to do viral loads at home so that once this is implemented in a real-world setting, it could be done with some of these home-based tests. And next slide, please. And I'd like to acknowledge our wonderful study team. That's really been a pleasure to work with, our clinical partners, our community advisory panel that's really given us so much information, our study participants, and people with HIV, treatment buddies, and clinicians. And then finally, our CDC partners, some of them who are in this photo here from their visit to San Francisco, Drs. Jesse O'Shea, Dr. Kate Bujas, and Dr. Kashif Enwal. And with that, I will turn it over for any Q&A.